Again, if you look over here on the right-hand side, the positive likelihood ratio of 7.36 for a procalcitonin greater than 2 in predicting presence of sepsis, as well as a negative likelihood ratio of 0.069 in excluding the presence of sepsis is very good and shows an area under the curve of 0.916, which is an excellent characteristic of a marker. In addition to being able to identify patients with sepsis, procalcitonin has the ability to add to the clinician's clinical impression. The lower line shows the sensitivity and specificity of a clinical impression without procalcitonin. When we add procalcitonin to a physician's clinical impression, we find that their ability to diagnose sepsis is improved. The next question that arises with regards to a biomarker is how to interpret that test. Here we see that a healthy patient will typically have a procalcitonin that is less than 0.05 nanograms per milliliter. And as a patient has a greater bacterial load and reaction to that, the procalcitonin levels will increase. Localized infections will be in the range between 0.05 and 0.5. This is also true for early infections, where it may take a few hours for that level to rise. Levels between 0.5 to 2 should be interpreted as systemic bacterial infections, and levels greater than 2 should be severe sepsis, and levels greater than 10 are generally considered to be septic shock. It should be realized by the clinician that procalcitonin does not go up with viral infections. It may, however, go up with fungal as well as parasitic infections. Procalcitonin typically does not go up with localized infections such as abscesses. It does not rise with autoimmune diseases or graft rejection, and may be of assistance in restratifying these patients as well. Low levels may be seen with patients who have either early presentations after the onset of their bacterial challenge, or in patients who have a very localized and focal infection. False negatives may be seen in immunocompromised patients. However, there is evidence that procalcitonin will rise in that subgroup as well. Oftentimes, false positives can be seen in patients with acute respiratory distress syndrome, malaria, trauma, and newborns less than 48 hours of age. A separate nomogram does exist showing the typical rise of procalcitonin in the newborn population, and it typically will return back to baseline levels within 48 hours. This quote by Dr. John Apley states that the physician should have faith in his clinical acumens and should treat the patient and not the laboratory reports. I think this is an important point, that no test stands well alone and has to be interpreted in the clinical context. I would be remiss if I did not point out one study by Jones, one that was published in Annals of Emergency Medicine, where they looked at all patients who had positive blood cultures, and in a meta-analysis, they looked to see whether procalcitonin could predict patients who had positive blood cultures. Unfortunately, they chose the wrong cutoff point, varying across the studies of 0.4 to 0.5, and additionally, they looked at the wrong outcome, which was the detection of blood cultures. I think a better gold standard would have been looking at the presence or absence of infection, as well as the presence of severe sepsis and septic shock. And thus, I think that causes some problems with this study in the event that you find this in your literature review. To close this session, I'd like to review one case, and this is a patient who is frequently arrives in my practice, and I'm presuming many of your own, patient who we'll call Ethel. She's an 87-year-old African-American female who presents to your emergency department from a nursing home. She comes in with an altered mental status, mild dyspnea, a little bit of non-productive cough. After searching through 8 pages of nursing home papers, reviewing bowel history and medications administered, you find one line that reviews her past medical history, and this shows that she has some mild dementia. To what degree, it's difficult to ascertain. Some coronary artery disease, congestive heart failure, chronic obstructive pulmonary disease, and some renal insufficiency. Her baseline creatinine is not known. You perform your physical exam in the noisy emergency department. You find that she has a borderline temperature, mildly tachypnic at 24, a heart rate that's slightly elevated at 95. She's borderline low in her blood pressure, but again, we're unsure of what her baseline blood pressure is, and we find that her pulse oximeter is in the normal range. She's obese, somewhat agitated, slightly inattentive to your presence, and she looks to have some labored respirations. However, the quality of your respiratory exam is less than ideal. You find her tachycardic. You can hear a 2 out of 6 systolic ejection murmur at the apex, as well as a 2+ edema. She has a chronic indwelling Foley catheter with some sediment within it. Reviewing your labs, you find that she has a white blood count of 10.4, an elevated creatinine of 3.2, but you're uncertain whether this is her baseline. Her BUN is greater than 7 millimoles, which translates to approximately 20. She has an elevated troponin T, which does have the problem of being elevated when creatinine is greater than 2, as well as an elevated brain natriuretic peptide level. That appears to be consistent with congestive heart failure. However, you recall from some of the work from Dr. Rivers that this can be elevated in sepsis as well, and a poor prognostic marker. Radiographic technicians come into the room, they shoot a portable chest x-ray, and the lady is slumped slightly to the side. Your review of it shows that she has poor effort, cardiomegaly, and it's difficult to see either base. Your analysis comes back, it's a Foley specimen, and obviously will show some white blood cells. In our first situation, we find that the procalcitonin was obtained and returns within an hour at 0.04. Based on this, a differential diagnosis of possible acute myocardial infarction, congestive heart failure, endocarditis, pneumonia, pulmonary embolism, acute renal failure, and urinary tract infection has been raised. And at this point, I will queue up the first poll question of what is the most probable diagnosis. So we can see by the results of the poll that the vast majority of people found that this could be congestive heart failure, possibly acute myocardial infarction, but still a quarter of the viewing audience believes that this might represent a pneumonia. I would say that this is possible. However, the probability of this would be very low, given the very, very low procalcitonin level. And then the last slide would be to take this very same situation and apply a procalcitonin of 6.2. And how does this affect the probable diagnosis? And we'll review with the same differential diagnosis. It appears that many people have used this to shift their votes from acute myocardial infarction over to and congestive heart failure over to pneumonia. Endocarditis still being a consideration by several people in the audience, but I think we can see that procalcitonin does have the ability to change your pretest probability, especially when many other factors in either history, laboratory testing, radiographic testing are ambiguous in nature. So in conclusion, detection of sepsis syndromes depends on our clinical impression, and that we can only start treating these patients once we've figured out that they have a sepsis syndrome, specifically severe sepsis or septic shock. We can use many techniques to stratify these patients, with lactate being the most frequently used, as well as the sepsis severity categories. However, both med scores, CURB-65, and rapid emergency med scores have been validated to show some ability to differentiate, and procalcitonin is a new biomarker that can accurately create a sepsis stratification. And finally, treatments are very highly time-dependent, and thus initiating early antibiotics and early goal-directed therapy are highly dependent upon rapid diagnosis. That concludes my portion of the talk, and I'll take it over to Steve to solicit some questions.
Thank you, Dr. Engineer. There are two I'd like to ask. I think they're kind of corollaries of each other, but one of them has to do with the references to the cutoff points along the continuum. And specifically, what would you do with a value of PCT that's less than 0.1 nanograms per mil?
I think we would all like that the answer would be that there is no systemic infection. Unfortunately, this hasn't been proven in the literature. We have to remember that we cannot throw our brains out the window. We have to interpret procalcitonin in terms of our underlying clinical impression, that if we are concerned about a patient being infected, that we should still keep that consideration available, and then consider retesting the procalcitonin several hours later to see if this has stayed constant or if the number has changed and increased over time.
So serial might be important in that setting.
Yes. And then I think we also have to look at, does this fall in one of the typical false negatives, be that early infection, localized infection, or subacute endocarditis?
And then the second question would be sort of a corollary to that, but just in general, if your PCT value appears discordant with your clinical impression, what do you do?
I put that into three different categories. If my clinical impression is that the patient's not infected, but we surprisingly find an elevated procalcitonin, I think the first thing I need to do is reconsider my diagnosis, obtain some cultures, do a chest x-ray, review the urine, and consider giving that patient some antibiotics in the event that my clinical impression is mistaken. The second scenario would be that the patient's infected, but I don't think it's very severe, yet the procalcitonin is very high. I think those patients really need to be observed. They need to be worked up further, and we need to get another serial procalcitonin level. If that procalcitonin is persistently high or gets higher, I think that's really concerning for a worsening inflammatory response, and we have to consider that this patient has early severe sepsis or early septic shock. And then lastly, if my impression is that the patient is clinically infected, but they have a very low procalcitonin, I have to ask myself, what are the non-infectious etiologies that I have not considered, and make sure that I've gone through, PE for shortness of breath patients who are febrile and other things similar to that.
Thank you. We have a couple of questions that have been written in. Given all the disclaimers you made earlier about when there might be false positives or false negatives, there's a question here that says, can PCT differentiate between viral and bacterial infections?
Yeah, I think that that's one of the most important uses for procalcitonin is differentiating viral, where it would be a very low level, and bacterial, where it will be high. Specific mechanism, I believe, is that the immune response secretes a protein that essentially suppresses the release of procalcitonin in virally infected patients, and thus you'll see a discordant difference between the two.
Okay. Here's a question that says, according to one of your graphs that you showed, that CRP had a higher sensitivity compared to lactate. And the question says, what makes lactate the ECG for sepsis?
I consider lactate the ECG of sepsis because an elevated lactate really spurs you into action. It makes you consider opening up the cath lab, placing a central venous catheter, assessing a central venous pressure, looking at your mean arterial pressure with an arterial line, and measuring your central venous oxygen saturation. So it's essentially your call to action to get things moving on that patient and to be aggressive with that patient.
Another question asks, how frequently should procalcitonin be monitored?
I don't think that data is out and well known. I've heard and seen people who measure it in 6-hour intervals or 24-hour intervals, and I don't think that data is really well described, and I don't think it's well spelled out in the FDA guidance. I would say that if I was really concerned about a patient, I would probably look at it again in 6 hours, and then once again 24 hours after my initial draw. But that's more off the top of my head than based on any specific literature.
Is the association of procalcitonin and sepsis seen in neutropenic patients?
This is something I've read discordant things about. I've read that patients who have neutropenia will not mount a similar rise in their procalcitonin. However, I've seen other studies, some in the pediatric literature, where they have documented that patients have had elevations of their procalcitonin as well. So I would say that if a patient does have an elevated procalcitonin, it should be concerning. However, a normal procalcitonin, at least based on literature that I'm aware of today, should not give you relief that nothing is going on. I do think that we have to find more literature, or at least publish more literature, before we know the answer to that question.
Okay. You showed some data talking about the rapid rise that you see with PCT. A question here says, how long does it take then for PCT to go back down following appropriate therapy?
Well, the half-life of the biomarker is estimated about 20 hours, so I would expect to see a difference by the next clinical day, and subsequently each day you should see a drop in the procalcitonin for patients who are improving. There are some studies that look at procalcitonin in respiratory infections where that evidence will probably be found best, and that would be in the PRO-RESP and the PRO-HOSP studies. But again, that does not really lead to risk stratification of sepsis syndromes.
Okay. I think with that, we have seen all the questions. That will conclude our webinar today. Again, we'd like to thank Dr. Engineer for his time and the excellent presentation. So with that, thank you very much for your attention and participation, and we thank you very much.